Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The NAIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Hello and good afternoon, everyone, to the next session of NAMS-AIIMS PGIMER Navigate Medico online CME program. This program is for the postgraduates and young faculty members and also for the medical officers who are posted in the periphery of India. So today we are with another very important topic, since we all know that bowel issues, that small intestine and large intestine issues are increasing day by day. And since there are 2 major diseases, one is ulcerative colitis and another one is Crohn's disease, and both of them they team up to make a diagnosis of inflammatory bowel diseases. So since a lot of people and a major chunk of population is suffering from these disorders, and since these disorders are very chronic and there are a lot of misconception, lot of challenges regarding the treatment. So today with us we have a very prolific speaker and a very important researcher, and I would say a very important personality, Dr. Vishal Sharma from PGIMER Chandigarh. So without wasting much time, I would like to request Professor A.K. Sood sir, Deputy Secretary of National Academy of Medical Sciences, for the welcome address. Over to you, sir.
Thank you, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, it is indeed my great privilege and pleasure to welcome the distinguished speaker for this afternoon, Professor Vishal Sharma sir. Thank you so much, sir, for being with us. I am sure that the practical tips which you will give based upon your experience on inflammatory bowel syndrome will be very useful to all of us, especially our PG student. I also extend a warm welcome to all the students, the young faculty members who have joined us. If you have any question, query or remarks, put your question or query in the chat box. Sir will be happy to answer. So once again, I extend a warm welcome to all of you. Over to you, Dr. Jaswant.
Thank you very much, sir. So since sir told that we are privileged to have Dr. Vishal Sharma as a speaker for today's session. So before starting, we would like to listen to the messages from Professor Digambar Behra sir. He is the President of National Academy of Medical Sciences.
My dear young colleagues, faculty and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you for the message from President NAMS. So next, I request Mr. Aviji to play a message from Professor M. Srinivas. Sir is the Director of All India Institute of Medical Sciences, New Delhi.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you for the messages. So now it's our turn to invite our speaker for the today. So Dr. Vishal Sharma is currently additional professor in the Department of Gastroenterology at PGIMER Chandigarh. He has special interest in inflammatory bowel disease. He has more than 400 peer-reviewed papers and multiple books on GI tuberculosis. He has numerous awards in his name, including SR Naik Memorial Award and MJ Shah Memorial Award. He has a lot of editorial responsibilities of various uh, uh, various journals in the field of gastroenterology, including Indian Journal of Gastroenterology, BMC Gastroenterology, and Journal of. He is also editor-in-chief of Journal of Gastrointestinal Infections. So, with this brief introduction, I would like to over the dice to Dr. Vishal Sharma. Sir, over to you, sir. Thank you.
Thank you, sir, for very kind words of introduction. I hope I am audible.
Yes, sir. You are very well audible.
And I do hope that my slides are also visible.
Yes, sir.
So today we have this topic of inflammatory bowel disease, which we'll try to cover in maybe 1 hour or so. So if we talk about inflammatory bowel disease, we will go over the epidemiology, risk factors, classification, diagnosis and differential diagnosis, assessment and monitoring. We'll talk about the drugs for IBD, which is an ever-expanding area. We'll talk about the therapy, approach to the therapy, and then we'll talk about some special situations. So coming to the epidemiology, so what is IBD? IBD is basically an autoimmune disease where there is an injury to the gastrointestinal tract. And what causes this injury is not very well understood, but it is believed to be because of a dysregulated immune response, which occurs to a ubiquitous antigen which is there in all, maybe all of us are exposed to that antigen, but certain genetically predisposed individuals, or when there is dysbiosis, then there is a dysregulated immune response which causes injury to our GI tract. Broadly, as was initially told, that IBD has two ends of the spectrum. One is ulcerative colitis and the other is Crohn's disease. Now, if we talk about these two entities, there are differences which help in making a discrimination. Ulcerative colitis, as the name says, is the disease of colon or the large intestine, and it typically will not involve the small intestine. It almost always will involve the rectum, and then the proximal extent is variable. Strictures, abscess formation, etc. are exceedingly uncommon, and this is largely believed to be a mucosal and sometimes submucosal disease, although some recent data suggests that it may also be a transmural disease. But one very important thing about it is that it is a continuous kind of a involvement. So there are no areas of normal mucosa in the region that ulcerative colitis occurs. On the other hand, Crohn's disease is something which can involve any part of the GI tract. In fact, sometimes it can also be extra-intestinal. Small bowel involvement is common, and it can also have intestinal strictures and fistulae, which make the disease more complicated. Obviously, on endoscopy, it is different from ulcerative colitis because there are skip areas, there are areas which are involved, and then there are areas which are relatively normal. and it is a granulomatous disease. And this is very important because another important intestinal disease in India, that is tuberculosis, is also a granulomatous disease. So these are the broad differences that these two diseases have. But if you can see here, there is some overlap between these two conditions. And approximately in 10 out of 100 patients, we are unable to say whether this is ulcerative colitis or Crohn's disease. And what we then call it is IBD unclassified. Now, sometimes it happens that even after colectomy, when the entire colon has been removed for some for management of a complication, even pathologists may not be able to say whether this is Crohn's or ulcerative colitis. In that case, the term used is indeterminate colitis. What causes IBD? I think we already talked that largely there is some interplay of genetics. So there may be some genetic predisposition, but the large amount of causation is on the environmental influences, which act through the GI microbiome, gut microbiome. And once there is dysbiosis, it results in immune mediated inflammatory processes, which results in injury to the GI tract. So as far as genetics is concerned, it can explain only 10% of causation. But it is the environmental influences which are very important. And the most important probably is the diet. Smoking has a role in Crohn's disease. Absence of green and blue spaces, which is because of the increased industrialization, increase in antibiotic use, NSAIDs, stress can also play a role, whereas breastfeeding is protective for IBD. Eventually, this results in all these factors would result in a reduced abundance of species in the gut microbiome. There's a decline in firmicutes and bacteroidetes and increase in proteobacteria. Eventually, there are immune responses. There is breakage of the gut barrier, and then, of course, it eventually results in inflammatory lesions. Now, if you look at the epidemiology of IBD, initially in a given region, there is emergence of the few cases. But over time, what happens is, because of the changes in environment, there is an increase in the incidence, and then the prevalence of the disease also starts increasing. Now, because this is a chronic disease, so somebody who develops disease will have this for the entire lifetime. Even when the incidence stabilizes, the prevalence keeps increasing until a prevalence equilibrium is reached. And these are the 4 stages, epidemiological stages of IBD. Most of the developing countries, including India, are probably now in the acceleration in incidence phase. So we are seeing an increasing incidence and prevalence of this disease. And if you look at this data from the GBD analysis over the last almost 30 years, you can see that in India, the orange colors shows the trend in India, and largely there is an increase in the IBD incidence and prevalence, which is contrary to the global trends where there is either stabilization or slight decline. Now, this is an interesting paper from Professor Vineet Ahuja, who looked at, who actually used population level studies which have looked at incidence of ulcerative colitis and also the prevalence. And then these were juxtaposed to the entire country. And the estimated disease burden of IBD in India is second only to the United States. So probably the number of patients that we have is extremely large, and many of them may remain undiagnosed or undertreated. Now, what is causing IBD, or what is causing an increase in IBD? And this is a very interesting paper which showed that in Europe, there were certain regions which had a very high plague. So there was an epidemic of Black Death or plague, and the regions which had a high rates of plague, these are the regions where there are a lot of NOT2 mutations. Now, these are the mutations which are associated with Crohn's disease, and these regions see very high Crohn's disease. In fact, it is now known that these mutations were probably protective in this particular, the plague epidemic. And obviously in the population, these mutations increased, and probably Crohn's disease is the price that these regions pay for surviving the Black Death at that time. But that obviously is not why IBD is increasing in India today. So we don't believe that it is the genetics, because genetics will not change in 1 or 2 generations to a large extent. So probably the most important influences are the environmental influences, and they are very elegant migrant studies. So this is a migrant study which looked at migrants in UK, and you can see that the Indian migrants seem to have almost as high rates as the indigenous people in UK for inflammatory bowel disease, especially ulcerative colitis. There's another study which looked at people in Ontario, Canada, and you can see that while in immigrants from South Asia, the rates of IBD were lower than the local population. But if you look at the children of immigrants, the rates were almost similar to the local population, which means that as you go to a new environment, the environmental factors will take over, they will change, and then there is an increase in IBD. But now the West has come to India through the food, through our lifestyle, the more of industrialization, and obviously we will see increasing number of IBD in India. So now we go to the classification of IBD. And although I briefly already talked that we have ulcerative colitis and Crohn's disease, but when we write the diagnosis, we have to write the complete diagnosis. For ulcerative colitis, this will include the extent of colonic involvement and the severity of the disease. For Crohn's disease, we are interested in talking about the age of diagnosis, the behavior, and the location. And then, of course, we have another entity, IBD, unclassified. So you can see on the basis of extent, we have 3 types. Proctitis, which is rectal involvement. You have a left-sided involvement, which is still the splenic flexure or less. Or you have extensive colitis, which may involve the transverse colon or the entire colon. In pediatrics, pancolitis is called E4. But usually in adults, even E4 comes under the category of E3 disease. So these are the 3 categories. And as you will see, that it is important in deciding what kind of therapy is to be used in a particular disease involvement. Now for severity, if the stool frequency is less than 4, it is usually believed to be mild disease, and then there are no features of systemic inflammation. On the other hand, if the stool frequency or the bloody stools are more than 6, and there is tachycardia, fever, or elevated ESR or CRP, this will probably be acute severe ulcerative colitis, and most of these patients will need admission. So if you talk about extent at presentation, it is highly variable. Some of the studies will show an equitable kind of distribution between the 3 types. But then there are studies which suggest that E3 disease or extensive colitis may only be 20 to 50%, and this varies from study to study. But what is more important to understand is that over time, the disease location of ulcerative colitis changes and there is disease extension. In fact, extension to E3 disease is almost 15% at 5 years and 50% after 25 years. And you can see here that there is quite a few number of patients who have extension beyond proctitis or left-sided colitis. Now, coming to the disease course, most of the patients have chronic intermittent course, that there will be relapses and then there are periods of remission. But occasional patients have ongoing continuous disease activity. And then a subset around 10 to 15% have a particularly aggressive disease which will not respond to most of the medical therapies and would require colectomy. Over 10 years, almost 10 to 15% of individuals will undergo a colectomy, and almost half of the patients of ulcerative colitis will require hospitalization during the course of their disease. Now we come to Crohn's disease. So Crohn's disease, we talk about age at diagnosis, and we are interested in this because probably the causes are different. At ages less than 16, probably the genetics may play more important a role as compared to a later diagnosis of Crohn's disease. Then, as I said, that Crohn's disease can basically involve any location of the GI tract. If it is confined only to the terminal ileum or the distal ileum, it is ileal, or the L1 location. If you have a colonic involvement, it is called as L2. If there is involvement of the ileocolonic area, it is the L3. And if it is an isolated upper GI Crohn's, which means either a jejunal involvement or a proximal ileal involvement, that is known as L4. Now, L4 can be added as a modifier if it is present in the presence of any of the other three types. And these three types are the more common types of Crohn's disease. Now, coming to their behavior. So what we have is B1 phenotype, which is just ulcers. And because this is ulcerating disease, largely presents with diarrhea. On the other hand, B2 is once you have strictures in the colon, as you can see here. And B3 is the penetrating type when you have these kind of enteroenteric, and this is an entrovesical fistula. And then what you have is a P, or a perianal involvement in Crohn's disease, which is used as a modifier to the other three subtypes. So these are the disease behaviors. Now, what is the natural history of Crohn's disease? So if you look at the time of diagnosis, you can see that there is almost, between the three types, it's almost equal. There are studies which show maybe slightly different trend, but especially in the elderly, it is noted that colonic disease may be more frequent. As against ulcerative colitis, the change of disease location is much more infrequent in Crohn's disease. Now, as you can see, what happens over time, about the phenotype, it is the inflammatory disease which is the common disease at the start. So almost 80% of patients or 70% of patients at presentation will have an inflammatory phenotype, and the others will have the complicated, that is stricturing or the penetrating type. But over time, what will happen, that you can see that the number of patients who have penetrating disease and stricturing disease keeps increasing with time, especially when it's an ileal involvement. Colonic involvement also, the complicated disease increases with time, although the increase is much less. And the inflammatory disease, obviously the more straightforward variety, decreases with time as these individuals develop strictures and penetrating complications. So now we have talked about the natural history of inflammatory bowel disease. Let us now spend some time to talk about the diagnosis and differential diagnosis. So when a patient comes to us, we want to say whether this is IBD or it is one of the mimics of IBD. And there are a lot of diseases which can mimic IBD. Then once we have made a diagnosis of IBD, we want to say whether it's a severe disease, mild disease, and what is the phenotype, and we can use the Montreal classification, which I talked about. Then we have to select the therapy. If it is an aggressive disease, we want to hit early, hit fast. That is what we call as top-down approach. On the other hand, if it's a milder variety of the disease, we may use a step-up approach. We have to take into account the cost of therapy, which can be very, very high for some of the therapies. We also need to educate our patients about the risk of colon cancer, their diet, the precautions they have to take, especially with respect to the hygienic food, vaccination, take care of the bone health and their mental health. So these are the broad roles a clinician has while managing a patient of inflammatory bowel disease. So how do we diagnose IBD? Unfortunately, there is no single test which can help diagnose IBD. It takes a combination of clinical, laboratory, which may include some of the fecal tests, endoscopy, imaging like CT, then histology, and sometimes even therapeutic trials to discriminate IBD from IBD mimics. And we will see this as we go forwards, how each of these approaches is actually used to make the diagnosis of inflammatory bowel disease. But the important point is that there is no single test which can clinch the diagnosis of IBD. And therefore, it is clinical judgment, largely taking into account the entire spectrum of findings, which helps make a diagnosis of IBD. So for ulcerative colitis, the diagnosis is relatively straightforward. You have a classical clinical presentation, which is in form of bloody stools, diarrhea with blood. You have rectal symptoms because rectum is involved almost always, and rectum is the reservoir of stool. So obviously when it is inflamed, it cannot contain the stool, and therefore there is urgency, frequency, and a subset of patients actually have proximal constipation because of the inflamed rectum. They may feel constipated, and there is a lot of stool which lies up, proximally in the uninvolved part of the colon. The diagnosis is typically with a sigmoidoscopy or a colonoscopy, which shows diffuse involvement of colon with a variable extent, and almost 90% of patients would have a rectal involvement. The classical findings I will show in some of the images, but it is histology, where not only do you find evidence of active inflammation, and we will see these findings, but also changes of architecture of colon, which suggests that this is a chronic disease. So these are some of the colonic images, colonoscopic images of ulcerative colitis, and you can see redness, hyperemia. You can see that there are some superficial ulcers here. This is a diffuse involvement. In fact, you can see that there is virtually no normal patch of the intestine or the colon here. And there's a diffuse involvement, and there's some bleeding also. So these are the findings that you see in ulcerative colitis. And then, as I told you about the extent, you can see that this is the normal area and this is the abnormal area. There's a very clear line of demarcation which separates the normal and the abnormal part of the colon. So these are the classic colonoscopic images for ulcerative colitis. Now, what are the differential diagnoses? Lot of differential diagnoses. In fact, anything which causes bleeding per rectum or bloody diarrhea can mimic ulcerative colitis. So this could be solitary rectal ulcer. It could be, in fact, any type of rectal ulcer, stercoidal ulcers. In a given setting where there's atherosclerotic disease, it may be ischemic colitis. History of pelvic radiation may be radiation colitis. And then there is, colitis which happens with diverticular disease, which is segmental colitis. These all can mimic ulcerative colitis. But probably the most important situation is when the confusion is with acute infective colitis. So just imagine a patient who's come with maybe 2 weeks history of bloody diarrhea, some amount of fever, and then you do a sigmoidoscopy and you see these kind of involvement with hyperemia, superficial ulcers, and bleeding. So whether this is infective colitis or ulcerative colitis is sometimes very difficult to discriminate. Presence of hectic fever, severe pain abdomen would suggest infective colitis. Usually it's a short history. If you diagnose the patients present within a week, mostly it is infective colitis. There may be a history of eating out or using unsafe water, unhygienic water or food. On the other hand, in ulcerative colitis, typically the fever is mild or absent, and there are dominant rectal symptoms. Tenesmus and urgency would be there. On investigations, there would be some suggestion in the microbiological workup, especially if multiplex PCRs, which are now available, are used. They will pick up an organism, usually in the infective colitis. They may occasionally pick it up in IBD also, because some of the flares are basically induced by infections. Sigmoidoscopy, you have a diffuse involvement in ulcerative colitis, but in infective colitis, it may be a diffuse or a patchy kind of involvement. The most important thing is histology, where in acute infective colitis, you will not see changes of chronicity or changes in the architecture of the colon. Whereas in ulcerative colitis, you may or may not see changes of distorted architecture. And these will be seen only if the duration of disease has been for some time, maybe more than 4 weeks. So let us look at some of these changes. So this is the normal colon, these are the crypts, and if you have neutrophils infiltrating around it, that is known as cryptitis. On the other hand, if the crypt is filled with neutrophils, it is known as cryptapsis. These are findings of acute inflammation, and they may be present both in ulcerative colitis and infective colitis. On the other hand, there are certain changes which are chronic changes. If at the base of the crypt there are a lot of plasma cells, which is basal lymphoplasmacytosis, this is actually the first feature of histological feature of inflammatory bowel disease. And then you can see that some of the times the crypts which are much more frequent here become infrequent, which is crypt loss. They may become smaller, shorter, crypt atrophy, or they may become branched, which is distorted architecture of the colon of the crypts. And these are changes which suggest a chronic disease. So these can happen with other chronic diseases also, but more likely that they would happen with inflammatory bowel disease. Some of the times you can have Paneth cell metaplasia. So these Paneth cells, if they are present in left colon, that is suggestive of inflammatory bowel disease. Now we come to Crohn's disease. And if we talk about Crohn's disease, actually the first description of ulcerative colitis was by Sir Samuel Wilkes, who performed an autopsy in a woman who was thought to have been murdered by her husband. And what he actually found was involvement of the small intestine and the cecum. And actually it was Crohn's disease, although he talked about it as ulcerative colitis, but this was the first time that this word ulcerative colitis was used. On the other hand, the actual first description of Crohn's disease was from this paper which appeared in JAMA, and you can see that virtually whatever we know today about Crohn's disease was described in this. So you could have terminal ileal involvement, you could have enteritic or inflammatory forms, stenotic or stricturing phenotype or fistulae, you could have involvement of the mesentery, you could have cobblestone appearance, the transmural nature of involvement was also mentioned, and that it is confused with gastrointestinal tuberculosis. And then the role of surgery. So virtually everything that we know today was mentioned in this paper about Crohn's disease. So as I said, clinical presentation is basically dependent upon the phenotype, inflammatory phenotype, ulcer dominant, it is diarrhea. It may be confused with irritable bowel syndrome, which a large number of people in population will have. And then there may be weight loss or anemia. On the other hand, if this is a stricturing phenotype, obviously that will result in obstruction of the GI tract and can result in pain abdomen. Then lastly, there may be a penetrating phenotype where there are fistulae, which may result in pain, obstruction, diarrhea. And then in perianal disease, there are actually perianal fistulae, abscesses. And this is a particularly debilitating disease because the patients are really having a very bad quality of life if there are perianal fistulae. Now, coming to the differential diagnosis, again, the list is large. Some of the infections like Yersinia, Shigella may mimic Crohn's. Intestinal amoebiasis can also mimic Crohn's disease. Others like Behçet disease, NSAID enteropathy, and sometimes even ulcerative colitis can mimic colonic Crohn's disease. But probably the most important, mimic in our setting is gastrointestinal tuberculosis. So these have similar clinical features. Both of them can have pain, obstruction, and diarrhea. They have similar imaging findings, and they can, ileocecal involvement can be there. There can be thickening of the bowel wall. They have similar endoscopic findings, ulcers, pseudopolyps, strictures. Both of them can have granulomas on the histology. And the problem is that GITB is a possibacillary kind of disease, and even with all the advances in the microbiological tests, actually the microbiological positivity is pretty low, and that obviously creates confusion with Crohn's disease. So if you look at the colonoscopic appearances, in TB, you have these ulcers which are transversely placed. So you can see that these are at a 90-degree angle to the direction of the lumen of the intestine. On the other hand, these are the longitudinal and to some extent serpiginous ulcers that are there in Crohn's disease, and these are linear, longitudinal to the, they are in the same direction as the lumen of the colon. Now, these are some of the classical images. You have ulcers and the intervening mucosa appears to be relatively uninvolved. So these are what are, so this is a discontiguous kind of involvement. And then these are the linear ulcers which can be there. And sometimes there may be early pseudopolyp formation, which gives sometimes the appearance of cobular stoning. Coming to imaging, so the top three images are of GITB. You can see that this is thickening of the bowel wall, and you can see that there is some kind of ulceration which is happening here. This is the cecum. Again, thickening of the bowel here, and you can see these necrotic lymph nodes with a black hypodense center here. On the other hand, in Crohn's disease, you can see that there are some strictures. So this is a narrowing here with thickening of the bowel. Again, some narrowing. And this is asymmetrical thickening. The mesenteric side appears to be thickened. And there are pseudo-sacculations, outpouchings, which you can see on the antimesenteric border. And then some of these vessels are prominent vasa recti in the mesentery. And then you can see that this is something like a comb or the comb sign. And here again, you can see mural stratification. The layers of the intestine can be seen separately. There is enhancing, and then there is black part and another enhancing part. So because of the edema, the bowel walls appear to be separated, and there is thickening of the intestine. So these are some of the the imaging findings. So how do we discriminate? So if you have a short history, hemoptysis, pulmonary symptoms, ascites, more likely tuberculosis. You have hematochezia, perianal symptoms, extraintestinal manifestations, most likely Crohn's disease. Necrotic lymph node, almost always it is TB if we are differentiating between these two. Right-sided involvement of the colon or the terminal ileum or the IC valve involvement suggests tuberculosis, but can happen with both. Changes in the fat of the abdomen, which is the visceral fat, where there may be proliferation of the fat, or there is comb sign, which is basically prominent vasa recta. These are more likely in Crohn's disease. Peritoneal involvement is more in tuberculosis. And I have already talked about the colonoscopic findings. On histopathology, if you have large granulomas, multiple granulomas, or caseating necrosis of granulomas, these favor tuberculosis. But if you have small granulomas, what are called as microgranulomas or occasional granulomas, that is more likely to favor a diagnosis of Crohn's disease. But sometimes doing all these tests, even after that, there is a subset you are not sure what is the diagnosis. So because in India, if you give steroids or immunosuppression, the underlying tuberculosis may flare. That is why the first approach is that we give ATT first. And in fact, this is a wonderful study which showed that even in patients who have Crohn's disease, almost a third of patients would have response to ATT. That is, their clinical symptoms will improve. Their diarrhea may improve. The pain may become less. So when you give ATT, there may be clinical response in both TB and Crohn's. So how do you ensure that this is TB? So what you do is a colonoscopy. And if you do a colonoscopy, you will see that the ulcers have healed. And if the ulcers have healed, it is almost always tuberculosis. Occasionally, the ulcers may heal in Crohn's, but this is very, very uncommon. And in fact, the problem is that there is now some data to show that the patients who receive ATT but actually have underlying Crohn's disease may develop a stricturing phenotype. In fact, there are multiple studies now which show that the ATT predisposes to stricture formation in patients with Crohn's disease. And therefore, we want to limit the exposure of ATT. And this is where there's our data, which showed that these healing of ulcers is visible as early as at 2 months. And you can actually clinch the diagnosis by doing a colonoscopy after starting ATT. So this is what a diagnostic trial is. You give ATT and you see what's happening. And similarly, in ulcerative colitis versus infective colitis, when you're not sure, you give antibiotics and see whether the infective colitis improves or whether it is actually ulcerative colitis. So diagnostic trial is actually a part of armamentarium of making a diagnosis in our country. So when we do endoscopy for Crohn's disease, we are looking at the location of the disease, the involvement, the severity of the disease. We take tissue for histology and also to discriminate mimics of IBD. There may be a role of upper gastrointestinal endoscopy, especially in the pediatric population, because there could be changes of Crohn's disease in the upper GI tract also. Now, sometimes it's only the small bowel which is involved, and this is beyond the reach of our standard upper GI and lower GI scopes. And therefore, we end up doing capsule endoscopy, and you can see that there are some ulcers which you can see here. And then you try to take histology using enteroscopy. But the problem is that because of the strictures which are part of Crohn's disease, there is a risk of capsule retention. And therefore, you do either a small bowel imaging, enterography, or a patency capsule to be sure that there is no narrowing and the capsule will not be retained. I've already talked about imaging. The best test to order is not a contrast enhanced CT, but a CT enterography, where a negative oral contrast is given and the bowel is distended. So you can see that there's a lot negative contrast here in the bowel, and the bowel is distended, and you can see the wall much more clearly, and you can see the thickening of the bowel here very clearly. So this is the technique of CT which should be ordered when we are suspecting inflammatory bowel disease. CT usually has no role in diagnosis of ulcerative colitis, but has an important role in diagnosis of Crohn's disease. Now people often prefer MR because virtually the same information can be provided by MRs without using ionizing radiation, and actually it's kind of safer to do MRs over time. But the game changer now is intestinal ultrasound. And in fact, earlier it was thought that bowel, you can't see on ultrasound. But nowadays it's become a very important tool to assess the bowel wall. And you can see actually responses to therapy very, very nicely with bowel ultrasound. Now coming to histology, most of the changes are similar to ulcerative colitis, but there are also granulomas, which are non-necrotizing granulomas with epithelioid histiocytes, which can be seen in Crohn's disease. Again, it's a granulomatous pathology just like tuberculosis. Now, we have talked about diagnosis and differential diagnosis. We'll now proceed to disease assessment and monitoring. So, for ulcerative colitis, we have a complete myoscore. This takes into account 4 symptoms: stool frequency, rectal bleeding, appearance of the mucosa on endoscopy, and a physician global assessment. And you can have a score between 0 to 12, and as the score increases, the disease severity increases. There is also an endoscopic score, which is the ulcerative colitis endoscopic index of severity, or a UCEIS, which looks at the vascular pattern, and you can see a normal vessels here. There's now you can see with some difficulty these vessels with patchy loss or a complete obliteration. You can see either there is absence of bleeding, some mucosal bleed, or mild blood or severe bleeding. You can see either presence of these small erosions, superficial ulcers, or deep ulcers. And on basis of this, you can have a score between 0 to 8. Again, as the score increases, the severity of disease increases. For Crohn's disease, there are 2 scores. One is a Crohn's disease activity index. The other is the Harvey-Bradshaw index, which basically take into account the number of stools individual is passing, the abdominal pain, presence of complications or mass or extraintestinal manifestations. And actually, Harvey-Bradshaw index is much easier to use. And of course, as the score increases, the severity increases. For Crohn's disease, the endoscopic score is the simple endoscopic score for Crohn's disease. There is nothing simple about this score, which scores all the part of colon and the terminal ileum, and then you score them for ulcers, narrowings, presence of narrowings, the percentage of area which is involved by ulcers, and the surface which is involved by the disease. And then you say whether the disease is active or in remission. So what are the tools to monitor inflammatory bowel disease? So for ulcerative colitis, you can simply ask clinical response, whether the diarrhea has settled, whether the bleeding has improved, whether the urgency, the inability to hold the stool, whether that has improved. So these are the clinical parameters which you can use in the clinic to follow these patients. A very important test is a fecal calprotectin. Now, this is a protein which is present in the neutrophils and is a marker of intestinal inflammation. When there are a lot of neutrophils in the colon, the fecal calprotectin rises. So this is a test which is used to differentiate IBS from inflammatory bowel disease. And in fact, if the levels are more than 250, certainly these are abnormal and suggest that there may be an underlying IBD. In fact, if some studies suggest more than 150. On the other hand, levels less than 50 microgram per kilogram of the stool suggest that probably you don't have an inflammatory pathology. Again, this can also be used to follow up. So an individual has a very high fecal calprotectin at diagnosis. Over time, as therapy starts working, the levels will fall. On the other hand, when you are following patients in remission, if there is an elevation of fecal calprotectin, even without symptoms, it may suggest that the disease is going to come back and there is going to be a relapse. As I said, there is a role of intestinal ultrasound, and endoscopy, of course, is the best method, but it is invasive. Crohn's disease, it's a transmural disease. So certainly you can use symptoms, improvement in symptoms, that is improvement in diarrhea, pain, but what is more important is the cross-sectional imaging, where MR or bowel ultrasound have a well-established role in looking at clinical response. And of course, endoscopy can certainly always be used to assess or to monitor inflammatory bowel disease. Now we come to the treatment of inflammatory bowel disease. And what we will do is that we will go over each of the therapeutic modalities, and at the end, we will try to summarize how to use these modalities. So there are dietary interventions, there are conventional therapies, there are advanced therapies, and then there are upcoming modalities. Coming to the dietary intervention, exclusive enteral nutrition, which basically is a formula-based feeding, and only formula-based feeding is used. It may be a tube feeding or a direct intake. Sometimes it is unpalatable because these are sometimes semi-elemental. So these have an excellent role in Crohn's disease, especially in pediatric Crohn's disease. And as you can see here, they have a role in induction of remission of Crohn's disease. Then you can use a partial enteral nutrition. And in fact, there is a diet, which is a Crohn's disease exclusion diet, which can also be used to induce and maintain remission in Crohn's disease. A lot of other diets are available, but the data is not very, very supportive. Also in ulcerative colitis, the role of dietary interventions is less well established. And there may be some role for Mediterranean diet, but as I said, the data for these is not very, very strong. Now coming to probably the therapy with which we have the maximum experience, which are the 5-aminosalicylates or ASAs as we call them. And you have sulfasalazine or mesalamine. And these are helpful in induction of remission and maintenance of remission in ulcerative colitis. And although they improve the symptoms in Crohn's disease, but they almost never will result in mucosal healing and actually are not recommended for the treatment of Crohn's disease. Now, there are different preparations. So you have this entire intestine, stomach, small intestine, and then you have a large intestine. So you have different therapies. So you may have a moisture release preparation, which gives drug both in small and large intestine. And if you want to use it, it may be reasonable for Crohn's disease or small bowel involvement. But again, the role is very less. As I said, that ASAs may not have an immense role in Crohn's disease. Then you have a pH release formulation, which typically gives the drug in the colon, and obviously this is going to be used in ulcerative colitis. Now, there are certain carrier-bound moieties, sulfasalazine, etc., which are broken by the gut microbiota, and therefore they will become active only in the colon. So that's the beauty of this drug, that because of the gut microbiome, these are broken down into the active moiety 5-ASA and the inactive moiety sulfapyridine, and the active moiety can act in the colon. So obviously these can be used in ulcerative colitis. The problem is that the highest inflammation usually is in the rectum, and the delivery of the oral drug is much less in the rectum. So you can have preparations. So these are local preparations. So if enemas are used, they can deliver drug up to the splenic flexure. But if it is only a proctitis, only a rectal involvement, the best therapy is a suppository. And in fact, almost entire drug is delivered in the rectum, and therefore for disease involvement of E1 type, suppositories are excellent therapies for ulcerative colitis. Now coming to steroids, these are excellent induction therapies. In fact, very high response rates, but they do not have any role in maintenance. So eventually you start at an appropriate dose, typically 40 milligram per day for adults, taper it over a variable period, usually less than 3 months. So you don't give steroids lifelong. You don't give steroids beyond 3 weeks. So you have to use steroid-sparing agents which can maintain the remission, because steroids will not maintain the remission. Now, typically for severe disease, we give systemic steroids like prednisolone. For less aggressive disease, we can use topically acting steroids, which are given orally, but they have a very high first pass metabolism like budesonide. And we want to avoid multiple courses of steroids because of the cumulative adverse events which can happen. So again, I've talked about the dose. There's no benefit of going to a very high dose of steroids. Typically 40 milligrams will work both in ulcerative colitis and Crohn's disease. Budesonide is a very good drug because it acts locally, very high first pass metabolism, so very little systemic exposure or suppression of the adrenal axis, and therefore this can be used actually in mild to moderate disease. There are 2 preparations available in market. One is the ileal release preparation, which delivers in the ileum and therefore can be used for Crohn's disease. And then there is a multi-matrix release preparation, or MMX preparation, which is released only in the colon, and therefore you can use it for induction of remission in mild to moderate ulcerative colitis. The dose for both is 9 milligrams, and typically you don't use it beyond 8 to 12 weeks. Now, thiopurines or azathioprine are agents of maintenance. They are very slow acting agents, and therefore you cannot use them for induction of remission. The typical dose for azathioprine is 2 to 2.5 milligram per kilogram. The problem is the adverse effects. They can have idiosyncratic reactions like pancreatitis, sometimes hepatitis, and then the other problem is the myelosuppression. I don't want to go into details of this, but you can see azathioprine is metabolized to 6-mercaptopurine, and then there are multiple pathways, one of which is the TPMT. So if TPMT is deficient, this goes through the HPRT pathway, and lot of 6-thioguanine nucleotides are produced, and these are the active component, and therefore there could be myelotoxicity. Now, the active agent is the phosphorylated form, and NUDT15 actually converts it back into the dephosphorylated form. So if the NUDT15 is mutant or is not working, this enzyme is absent or has low activity, the active form will stay on for a long time, and therefore there will be myelosuppression. Now, this is a busy slide, but what I want to say is that although the Western textbooks always talk about TPMT, in India, it is the NUDT which is more important. And this is a systematic review we did. We showed that NUDT testing is more important than TPMT testing before starting thiopurines. And of course, the other tests like viral markers should also be done. With EBV, especially if individuals are EBV negative, there is a small risk of developing very severe HLH. with the thiopurines. If patients are homozygous for NUDT, we avoid thiopurines. If they are heterozygous, we use lower doses. And if it is a normal variant, then we start with a standard dose and then increment over 1 to 2 weekly intervals and monitor with hemogram and liver function tests. Now we come to the advanced therapies. So let's say the basic, the conventional therapies have been used and they're not working. Then how do we move forward? So then we use advanced therapies, and then these could be biological agents or small molecules. Biological agents are monoclonal antibodies, which are complex proteins synthesized in living organisms, and therefore these have long half-life, parenteral administration, and are costly. Small molecules are standard pharmaceuticals which have short half-life and have an oral administration and are relatively cheap. So anti-TNFs in IBD act by neutralizing both the soluble and the membrane-bound TNF, and then they can induce apoptosis of the inflammatory cells, and there is antibody-mediated cytotoxicity, which may result in the helpful action. So we have infliximab and adalimumab, which act both in Crohn's disease and ulcerative colitis, certolizumab in Crohn's, and golimumab for ulcerative colitis. The problem is that these are very efficacious agents, but they can increase the risk of infections, especially TB. A combination with thiopurines may increase risk of lymphoma. They may induce some autoimmune reactions also, and then over time there may be development of anti-drug antibodies, and then there could be infusion reactions or loss to response with time. The second agent that we have are alpha-4 beta-7 inhibitors. Now this is a receptor in the gut which helps in the transmigration of the lymphocytes into the intestine from the blood using attachment with MADCAM. And if you block this, obviously the lymphocytes will not reach the site of inflammation, and therefore these drugs can be very, very efficacious. And because they act only on the gut, vedolizumab, it is very, very safe drug, and there are no reports of PML, which happened with the natalizumab, which was a non-specific blocker. So vedolizumab is a very, very safe therapy. Now what we have are combined blockers of IL-12 and 23. So if you block P50, which is there in receptor of both of these, you can stop the action of IL-12 and IL-23, which is ustekinumab. And then if you block only the IL-23 pathway, which is P19 blockers, you have guselkumab, mirikizumab, and risankizumab, and all of these drugs are going to come to India very soon. Ustekinumab actually is available. Now we come to JAK inhibitors. So you can see that there are 4 JAKs, and then there are, this is extracellular, and therefore they modulate the intracellular STAT, and then eventually gene expression in the nucleus. So if you block them, then many of the cytokines are blocked. The problem is that because it's a very non-specific blockage, they can be used in multiple immune-mediated inflammatory disorders. But the problem is there is a high risk of non-target action and adverse events, and there's a relative lack of specificity. So there is an increased risk of infection, but we are worried about the major adverse cardiovascular events and venous thrombosis, especially in the elderly, is an increased risk of herpes zoster, and these drugs are not suggested in individuals with history of malignancy. There is another drug which is not yet available in India, but which is again which basically sphingosine 1-phosphate receptor modulators. And what they do is that they ensure that the lymphocytes don't leave the lymph node to the lymph and don't actually go to the site of inflammation. So they stop the egress of the lymphocytes. And examples are ozanimod and etrasimod. Now, because these receptors are present elsewhere also, so obviously there are chances of bradycardia, especially initially, and therefore the dose is increased slowly. These drugs, so if we summarize all the therapies, we have ASAs working in ulcerative colitis, steroids in both, but only for induction, thiopurines only for maintenance, the monoclonal antibodies that we have work in all, but tofacitinib, which is pan-JAK inhibitor, JAK1 and JAK2, and some amount of JAK3, it works only in ulcerative colitis. Upadacitinib is a pan-JAK inhibitor, which works across ulcerative colitis and Crohn's disease, and we have S1P modulators, which work only in ulcerative colitis. lastly, I'd like also to talk about surgery. For ulcerative colitis, surgery is a cure. You take out the entire colon, a colectomy is done, and then a reservoir which mimics the rectum is created out of the ileum, and that is known as ileal pouch, and it is anastomosed to the anal canal, and therefore it is a IPAA, ileal pouch anal anastomosis. For Crohn's disease, you can do a bowel resection of the involved area, or you can do a stricturoplasty, dilate the strictures, and then do different types of stricturoplasties. But Crohn's disease does not cure. The surgery for Crohn's disease does not cure the disease. But it has been shown that if early surgery is done, especially in limited Crohn's disease, let's say 30 to 40 centimeters involved, and then all of it is taken out, it may actually be better than use of biologics and can result in a long-term remission in a large subset of these patients. So we have two types of approaches. We can step up the therapy. We start off with the basic drugs and then go up. And this is what the approach we typically use for ulcerative colitis. On the other hand, the top to bottom approach, where you use aggressive therapy early on, because it may change the course of the disease and decrease the complications of disease. That's the strategy which is suggested in Crohn's disease if the patient is afforded. So you choose your patient, you stratify the risk of progression, and then you use the therapy and then reassess the targets at different times depending upon the therapy that is used. If the therapy is working, you continue the therapy, else you change the therapy and try to get to your target, which is known as treat to target approach. Now, early aggressive therapy in one profile trial has been shown to be better than the standard therapy, which is steroids and immunomodulators, and this was compared to infliximab with immunomodulator, and the top-down approach was better. And a strategy which employs use of biomarkers, CRP and calprotectin, along with clinical response, and that is known as tight control approach, was better in achieving remission in patients with Crohn's disease. So these are the various approaches which can be used for treatment of Crohn's disease. There are a lot of head-to-head trials which are important so that we know the relative efficacy of these drugs. So vedolizumab has been shown to be better than adalimumab, but we don't have a direct comparison with infliximab. In a comparison of risankizumab with ustekinumab in Crohn's disease, risankizumab was better, but most of the other trials show that these therapies may be similar. The problem with all these therapies is that none of them work in more than 50% of the patients. So any therapy, you will see the response rates are 30 to 40%, certainly not more than that. And therefore, there's a need to break this therapeutic ceiling. And this can be done through early diagnosis, risk stratification, advanced therapies, combining the advanced therapies rather than using a single therapy, and improved target-driven approach. So these are the strategies used to improve clinical responses. So I think I'll now briefly talk about 3 to 4 important special situations, and this will be the last part of the talk. So we have acute severe ulcerative colitis when patients have very high stool frequency of more than 6 with bleeding, and then you either have tachycardia or elevated CRP or fecal calprotectin. So these are the patients you hospitalize, and the reasons could be use of this could be use of NSAIDs, GI infections, non-adherence to medication, or actual disease activity. We do a sigmoidoscopy, take biopsies to rule out CMV. We start intravenous steroids. Antibiotics do not have a role. There is no need to keep them nib per oral unless there is a toxic megacolon. We give anticoagulation to all hospitalized patients of inflammatory bowel disease and surgical consult for acute severe ulcerative colitis on day 1. If there is, we use hydrocortisone or methylprednisolone intravenous. If there is no response on day 3, that the stool frequency is still high, or it is moderately high with the elevated CRP, we go to a second line therapy, and these are the Oxford criteria. We use a rescue therapy, which could be a medical rescue or a surgical rescue using colectomy. The medical rescue could be infliximab or cyclosporine. Both of these are equi-efficacious. We use cyclosporine in, this is so relatively cheap, and then you can use in people who are ASA naive. Now, you can use these in low patients with low albumin. Infliximab is typically used in patients with previous azathioprine exposure, and you can continue these patients on infliximab for maintenance also. There is upcoming role for tofacitinib and upadacitinib, which are JAK1 inhibitors, but the actual role or the place where they should be used is still emerging. Some people use them as first line also, actually, but typically they should be used as a second line therapy. Now, the surgery is needed in medically refractory disease. They are not responding to the medication. Lack of response to second line therapy, people who don't afford a biological therapy. If there is a perforation or if you have a toxic megacolon, as you can see that the transverse colon here is more than 6 centimeter. So these are the patients who will need surgery. Then we come to the stricturing phenotype, where you have thickening of the bowel, narrowing of the bowel, and then there is a proximal pre-stenotic dilatation. So if you have any two of these, you say this is a stricture because of Crohn's disease, and then you assess the risk depending upon whether the stricture is going to respond or not respond. If it is a high risk, like aggressive disease, penetrating disease, smoking, then directly go for surgery. If it's a medium risk, one can try medical therapy, especially with anti-TNFs and immunomodulators, and the strictures can be dilated using colonoscopy. Now, the next special type is the perianal fistula, which is one of the worst diseases. In fact, one of the most difficult to treat diseases. You classify the perianal fistula as either simple, which are low fistulas, don't involve the sphincter, there's a single opening, there's no abscess. On the other hand, complex fistulas are difficult to treat. They are high fistulas, involve the sphincter. There may be multiple openings, horseshoe type fistulas. There may be associated abscesses, and they may connect to the adjacent structures. These will need control of pelvic sepsis, drainage of abscess, use of antibiotics. Then we put a ceton, which is a non-cutting. It's just a draining ceton. Early initiation of biological therapy, especially anti-TNFs along with thiopurines, and then later on ceton removal to assess for, and then over 6 months we assess whether the fistula have closed or not. If they have not closed, then closure surgeries can be done, but it needs that the proctitis or the rectal involvement has been taken care by the drug therapy. Now, there is a risk of colon cancer in these patients, both ulcerative colitis and colonic Crohn's disease. Therefore, we do a colonoscopy at the diagnosis. This is especially for PSC, where PSC IBD has a very high risk. Primary sclerosing cholangitis along with IBD has a very high risk of colon cancer. And then for everybody, we do a colonoscopy at 8 years of diagnosis, and then we stratify. If there is a very, very high chance of colon cancer with active inflammation in spite of medical therapy, patients can be taken up for colectomy. If it's a moderate risk like PSC, strictures, or dysplasia in the past 5 years, you do annual surveillance. For a smaller risk, you do surveillance every 3 years. However, if the disease involves only the rectum, then probably it's a low risk situation and you do not need to do a surveillance colonoscopy. Now, coming to post-operative recurrence, as I said, with Crohn's disease, post-operative recurrence is always there. And it's only that in some individuals, it's pretty quick. In others, it takes a bit of time. And what we do is a Rutgers scoring. So this is the new terminal lining created after surgery. And you can see that there could be small aphthous ulcers or they could be deep ulcers. And depending upon that, you say what is the severity. If you have a high score, you say that these are the individuals where you need to change therapy. If anyway the patients have a complicated phenotype with a B3 or a smoking and a myelin plexus or a young age, you start them on biologics. Otherwise, you give just metronidazole and then do a colonoscopy at 6 to 12 months. And then these patients need to be followed at 6 monthly with fecal calprotectin or bowel ultrasound. Lastly, about pregnancy and lactation. These patients have increased voluntary childness because they are afraid of the side effects and risk of disease in the children. But usually, if the disease is well controlled, pregnancy is not a problem. Most of the therapies are safe. Vaginal delivery is safe except in perianal fistula and in patients who have earlier pouch surgery. Infertility risk is high, especially in pelvic surgery like the pouch. And these patients have an increased risk of preterm birth, spontaneous abortions, or a VT. As you can see that most of the therapies are safe in pregnancy and lactation. except methotrexate, which should be stopped 3 months, JAK inhibitors, which should be stopped 4 weeks, and sphingosine 1 modulators, which should be stopped 4 weeks to 3 months before conception. Now, if biologics are being used, one has to be careful with vaccination in the newborn, and one should avoid BCG vaccination in the newborn during the initial time. IBD is associated with multiple extraintestinal manifestations, like in skin, there could be pyoderma, erythema nodosum, there could be arthritis, there could be primary sclerosing cholangitis, and then there could be uveitis, scleritis. Some of these EIMs are useful in deciding which therapy is to be used. And if we talk about the recent advances, then fecal transplants have been shown to be useful in ulcerative colitis, but not in Crohn's disease. There is a lot of interest in TNF-like ligand 1A blockers, and in these drugs there are already trials which have been published which show promising results in ulcerative colitis and Crohn's disease. There is also a shift towards subcutaneous preparations from the traditional intravenous, especially for infliximab and vedolizumab, and these are either equally efficacious or even better. Now, a lot of biosimilars are available for biologics, which have brought down the cost of therapy. And then there is a role of combination therapy in individuals who are not responding to a single advanced therapy. So these are all things which are happening or have happened in the recent times. To summarize, IBD is increasing in India. It has got a high morbidity and impacts the quality of life. But with proper treatment, actually the lifespan should be normal. Infections like GI, TB, or infective colitis are important mimics of IBD. Unfortunately, there is no single gold standard for the diagnosis, and it depends upon a combination of factors. Therapy, you basically induce the disease remission and then use the therapy to maintain remission. You can use a top-down approach or a step-up approach depending upon the kind of situation that you're dealing with. Crohn's disease, top-down ideally, and step-up in ulcerative colitis. Surgery is a cure for ulcerative colitis, but disease recurrence is common in Crohn's disease. Thank you for your attention. I'll stop here.
Thank you very much, sir, for this amazing session. Starting from epidemiology with then diagnostic challenges, then clinical presentation, and the difficulties, like they're often it often mimics with the TB and other infections, and the therapeutic advances. So thank you for this elaborative presentation. So I would request the participants to write the questions in the chat box. They can put their queries, doubts, suggestions, anything in the chat box. So we have two questions from YouTube. So one of the participant is currently working as medical officer in one of the CHCs in Madhya Pradesh. So she asked that how we can differentiate gut tuberculosis from IBD without endoscopy, since this facility is not available at their district hospital.
So I think it's a very pertinent question, especially when we are working in a resource limited setting. So I will tell you about what ICMR suggests, and there are guidelines for that, and I'll also talk about what some information or data that we have. So if you have gene expert available, and which is available through the National Tuberculosis Program, you can do a stool PCR. Now there is limited data, one study which shows that it can be positive. If it is positive, you may say that this is TB. Now this is whatever little evidence that you have. But if you look at the ICMR strategy, these patients should be referred for colonoscopy, because that is the way you make a diagnosis. There is no way that you can be sure of the underlying diagnosis in absence of a colonoscopy and histology and microbiology.
Right. Thank you, sir. Sir, there is another question. If a patient with ulcerative colitis, like if they want surgical treatment in the beginning without any induction phase or anything else, like just to avoid chronic medications or chronic treatment, so if they just prefer for the surgical treatment, so what should be our advice for that particular patient?
I think this is again a very, very interesting question, because this approach has changed over time. Initially, when you did not have many therapies, surgery could have been a reasonable option. And because it is the cure of disease, the risk of cancer basically ends. But we must remind the patient and inform the patient that surgery is the cure of the disease, but it is not end of the story. Because after a pouch is done, now this is a man-made reservoir. It is not going to be equivalent to God's reservoir. So the stool frequency is high. I mean, they will always have a stool frequency of 6 to 8 or even more. There are complications related to pouch surgery which can happen. Pouchitis is a frequent complication. Pouch failures can happen. There could be strictures, fistulae. And then you eventually again go to the same therapies. The therapy for pouchitis actually is the same that you use for IBD. I mean, if antibiotics don't work, then the next strategy is using the therapies for IBD. So you give the patient the options, you tell the pros and cons, and then I think it's a call which the patient has to take.
Thank you, sir. Like that clears doubt, I think, completely. Even I had the same query when I saw this question. That yeah, definitely. What should be our advice? But like your opinion and your advice is very effective. I think it will be helpful for our participants. So, sir, another question that I personally had a doubt. There are like many Ayurveda practitioners who did their MD in Ayurvedic medicine, that Kaya Chikitsa, from Gujarat and from Kerala. So, like they often claim to have a permanent cure for even Crohn's disease. So, matlab, have you gone through any kind of literature?
So, as you would understand that I am a practitioner of modern medicine,
Sir.
and I am ill-placed to talk about that. But whatever little we know, I will talk about that. So there are certain complementary medications which may have a role in treatment of IBD. So you have curcumin, and there are multiple randomized trials which have shown that it could be efficacious. The problem is that they are not very effective. The second therapy that you have is indigo naturalis. Now, this drug, unfortunately, is not available in India, but it's used in Japan, and there are very, very rigorously conducted randomized trials which have shown that these are very effective for ulcerative colitis.
Okay.
If you look at Ayurvedic literature, you would have heard about the bale patra, the bale fruit,
Right.
which we offer to Shivaji for so that has been described to be useful in IBD like diseases, but there are no human studies for that. So this is broadly what we know about the whatever the scientific evidence is there. For Crohn's disease, unfortunately, I'm not aware if there is any good quality data to show that these drugs are efficacious. Whenever they have been tested with modern tools of randomized trials, they improve the disease but do not cure the disease. I mean, the ones which I've talked about.
Right. Thank you, sir. Sir, another doubt that I had, since in this era, as the treatment and other things they are advancing, we have a lot of monoclonal antibodies which are coming up for all the immune-related disorders of various parts of body. So, like there are two modalities that I have heard a lot. I have in like various discussions. One is this monoclonal antibodies, and one is this fecal microbiota transplant. So, how effective or how efficacious are these new modalities as compared to our traditional modern treatment?
So I will, we are all excited about the recent advances.
Right, sir.
I will start off with a word of caution that none of the therapies work in more than 30 to 40% of patients. So even if they are very costly, the costliest therapies, none will work in more than half of the patients. Infliximab, when the drug was, first, actually it was a drug which was discovered actually for sepsis. The initial evidence came in rheumatoid arthritis, but the first approval came for Crohn's disease. And if I remember the image on the gastroenterology cover showing complete healing of the ulcers, but then we learned that after induction, the disease recurs. So you need a maintenance dose. Then we learned, okay, when you keep giving this drug, the antibodies are formed, and then there is a loss of resistance. Now in IBD, there are multiple pathways. So if you block one pathway, the others become active. And then you have to shift the therapy. So, I mean, obviously, these are efficacious therapies, but they don't last really a lifetime. The second thing you talked about, fecal transplants. I think there is enough data which is supportive of their use in ulcerative colitis, but not in Crohn's disease. The problem with fecal transplants is that there is also evidence of harm. In some of the trials, mortality and transmission of drug resistance has been noted. So it is important that the donor selection is very, very carefully done. In fact, there is a ICMR funded ongoing project led by Professor Vineet Ahuja from AIIMS, of which we are also a part, where 4 randomized trials are going on at this moment across 6 centers in the country, which will definitively answer this question, whether FMT is beneficial in ulcerative colitis or Crohn's disease. I think another 3 to 4 years, we will have an Indian answer to this question.
Thank you, sir. Thank you for the update regarding this multicentric random RCT. And that definitely that's going to answer a lot of queries, and that's going to help people. So, sir, there is another question. Like if, since we all know that in Crohn's disease, the immunity is lowered, and at times, like the patients, they are very prone for infection. So a person is already suffering from Crohn's disease, and he is under treatment, and he develops now tuberculosis. So, like our treatment and diagnostic approach should differ, or like it should be the same.
So I would like to answer this in 2 parts.
Sure.
One is that a patient with Crohn's disease, we should make all efforts that does not develop TB. So how do we do that? Whenever we start, unfortunately, because of the shortage, I did not pay much importance, or I could not discuss the latent TB part. Now, we do a stringent testing for latent TB using a MON2, chest X-ray, exposure to tuberculosis, and interferon gamma release assay. And if the person is positive for a latent TB, we actually give a prophylactic therapy. Ideally, that should be given 4 weeks before starting immunosuppression, or if the need for immunosuppression is urgent, you can give it together. This is the first part, that you have to reduce the risk of TB reactivation, which can happen with these drugs. Now, coming to the second part, if unfortunately somebody develops TB, we have to stop the immunosuppression. There is nothing else which can be done. And this is especially true for steroids and TNF inhibitors. And you give ATT for 2 months, prove that it is microbiologically negative, and after that, you can again start the therapy while the patient continues to be in ATT. Some of the therapies, for example, if you develop TB on vedolizumab, probably you can continue vedolizumab, which, there are very occasional case reports. In one of our patients, we continued vedolizumab because that's a gut-specific therapy. So it's not going to result in dissemination. But again, we have to individualize approach. And for most of the biologics, it is suggested that we stop immunosuppression and then, restart it maybe two months later.
Right. Thank you, sir. So I think that answers the query from the participant who is on our Zoom. So if there is any other query, So, and if they are lazy enough to type it in the chat box, they can just raise their hand. We'll unmute them and they can ask the questions.
Sir, are there any genetic markers predicting for development of Crohn's?
Again, a very interesting question. As I briefly talked about the NOT2 mutations, unfortunately or fortunately, they are not present in the Indian population. So, if you look at the spectrum of IBD, there is a spectrum of pediatric IBD, and then there is a very early onset IBD, where the role of genetics is much more important. And you have many monogenic diseases which cause IBD. So there is a clinical exome sequencing which can be done, and I think till now more than 200 different genetic loci have been associated with IBD. The problem with adult IBD is that it's usually a polygenic kind of a situation, and usually you do not have a single gene which is resulting in causation of IBD. So typically, if you have additional features, you have severe perianal disease, you have multiple family members involved, or very early onset IBD, that is the situation, or immunodeficiencies associated. That is the situation where you may want to do a genetic testing.
You mentioned about the vaccination. What vaccinations you prefer then?
So it is basically the same recommendations as you would typically have for adult vaccination. So hepatitis B, hepatitis A, entire spectrum of DPT, MMR. One important addition is the zoster vaccine, especially if you're planning to start drug like JAK inhibitors, which increase the risk of zoster. Then annual influenza vaccine, HPV, especially in females. So these are the vaccines which are recommended. Unfortunately, even in the best of centers, the uptake is very low because we don't have a very strong adult immunization program. On the other hand, we have a very good, the child program. But I think we hope that this adult immunization program is established, and the cost is also a problem. So some of the vaccines are very costly. So and with the cost of drugs, it becomes a bit difficult for the patient also.
Yeah, you mentioned about the calprotectin. How much is the significance of serum calprotectin compared to stool?
So very limited data, but there are some studies which have looked at serum calprotectin.
People are doing regularly nowadays.
Okay, that because we don't do it in our clinical practice, because the data is very, very good for fecal calprotectin, because this is directly measuring the inflammation at the site of inflammation. Serum calprotectin has been shown to correlate with disease activity, but probably I don't think there's any data to show whether it can discriminate IBD from IBS. And again, the discriminative value is not as high as fecal calprotectin. In fact, serum calprotectin has also been used in other immune-mediated inflammatory disorders, apart from IBD.
Are there any data to suggest that IBD transformation to malignancy?
Yes.
Percentage?
Yes.
How much is the percentage? Yeah, we have seen few cases developing gallbladder, this thing and all.
Okay. So now, so two things. What cancers there is an increased risk? Certainly colon cancer, which I talked about. Probably if you are on infliximab with thiopurines or thiopurines alone, there may be small increase in risk of lymphoma. There is limited data about JAK inhibitors, but I don't think beyond this, there is a strong data to show increased risk of cancer at other locations.
Yeah.
Thank you, Dr. Sangha, for the
Yeah.
interesting questions. So there is another question in the chat box. Like again, a patient with Crohn's disease is on treatment, and now he has achieved remission. Like the most of the symptoms are now resolved, and again he develops diarrhea and GI symptoms. So, like, what should be our approach, diagnostic approach, to differentiate between the disease flare up and infection? Like, once he's on immunosuppression. Yes.
So I will again talk about two strategies. One is the ideal strategy, which if you have enough funds, you are in a private sector, you order a GI PCR, fecal PCR. The cost is there, but it's a good test. I mean, there is now enough data to show that it can discriminate infectious flares from inflammatory flares in IBD. So if facilities are not a problem, please do a GI PCR, and if it is positive, treat accordingly. Negative, then evaluate for inflammatory disease and go forward. What do we do practically? Now, the cost is more than 10,000, even if you do a local PCR, multiplex PCR. So you do a standard approach. You do a stool over cyst, look for amoeba. You send a culture. Again, some of them may be positive on culture, but you also give an antibiotic and you keep evaluating. So if they respond, you say it's an infective flare. If they don't respond, you do a colonoscopy, find evidence of inflammation, and then treat accordingly.
Yeah, that's very easy approach considering the financial status of majority of our patients. So thank you, sir. It was indeed very interesting discussion for this presentation. So if there is any other doubt, any other person, other participants, they do have doubt, they can last minute they can raise any queries, doubts. Okay. So
this before this era of diagnosis of IBD and ulcerative colitis Crohn's, there was a diagnostic test like empirically treatment with ATT that solved us many problems. So now is there any hype for this IBD and Crohn's?
So as you said that GITB is an important mimic of Crohn's disease. They have ileocecal involvement, they have granulomas, they have ulcers. So I would say that in our clinical practice, even today, 1/3 of patients of Crohn's disease receive antitubercular therapy before we make a diagnosis of Crohn's disease. And this is an approach which is suggested in TB endemic regions where you cannot discriminate between these two entities even after extensive testing. So this is a approach which is suggested in ICMR guidelines also, and also in the European consensus for treating IBD in lower middle income countries, especially TB endemic countries. The important thing to remember is that we do a colonoscopy at 2 months to see whether the ulcers have healed after ATT. If they have healed, we are rest assured that this was TB, and we complete the 6 months of therapy. If the ulcers are the same or they've worsened, we take biopsies again. There are only two possibilities: either a drug-resistant TB, which is uncommon in GI, and the second possibility is Crohn's disease. So we treat accordingly.
thank you, sir. Thank you for the interesting discussion. So I think now we can wind up the discussion part, since there is paucity of time for, I think you must have some commitment. So now I would like to request Professor A.K. Sood, sir. He is the Deputy Secretary of National Academy of Medical Sciences for the word of thanks. Over to you, sir.
Thank you so much, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, I am really grateful to the speaker, distinguished speaker, Dr. Vishal Sharma, sir, for covering this topic very comprehensively and also answering the queries and questions of the participant. So we look forward for your support and blessing in future also. Thank you, sir. I also take this opportunity to thank all the directors, principals, senior faculty members who have been supporting this program. And I request them that it is your own program. And if you have any suggestion for the topics, and if you want to take some session on this platform, please come forward and write to us. We'll be happy to involve you in this program. For the participant, there is some information that the next session is on 3rd of October, which is the last session of the ophthalmology series. And in this session, we are going to cover about eye bank and eye donation. So this is going to be another interesting session. And on 17th of October, again, we are going to have a session on how to manage headache. Headache is a very important issue. So how to properly manage headache. For that, again, we have an eminent speaker from PGIMER, Dr. Astha Kakkar. And that, again, session is going to be very useful for the participant. So if you have any queries, you can write to us and we will share with the speakers so that these are covered during the session. Another information for PG student is that we have a ICMR NAMS biostatistical helpline, and the students, especially when you want to seek help for your thesis, experts are available online, and you can always book a slot and interact with the experts. So far, more than 250 PG students have utilized this facility. for our faculty members who are attending this session, we have another interesting program coming up in the month of October from 23rd to 25th October, 3 days program, national conference at NAMS, where the leadership development is going to be a very important issue. So under faculty development program, I will request the senior faculty member, you can apply for that. And it is going to be a very interesting session where the eminent leaders in the medical fraternity, they are going to share their experience. They have headed the different institution under the Meet the Leader program. So that is another information. And another interesting information is for all the fellows and the faculty members and also for the PG student, we have the annual national conference of academy at PGI Chandigarh from 7th, 8th and 9th of November. So for PG student, they are going to be very interesting CME programs and also certain panel discussion. And we have shared the detail of this brochure in the chat box. So those who are interested, they can just look into that. And once again, I like to thank Dr. Jaswant, who has been moderating this session very well right from the beginning. And today also he has generated a lot of discussion. Thank you, Dr. Jaswant, for sparing time for the Academy. We are really grateful to you for your support. I would also like to thank from NAMS, our IT team under the leadership of Mr. Ravi, who has been writing to you and also ensuring that the transmission is done on the Zoom as well as on the YouTube. Mr. Shivam is also helping us for organizing this session. And all these sessions are available, video recordings are available on NAMS website. You can just log in the NAMS website and download the videos and view this session. More than 80 sessions we have on the website. So once again, I thank you all for being with us and making this session very, very interesting and interacting. Over to you, Dr. Jaswant.
Thank you, sir. Thank you very much. I just got a personal message and Sud sir just answered this question. The question was regarding that one patient left, one of the participants left the discussion for a patient and then he joined. So he missed a part. So as sir said, this session is being recorded and will be uploaded on the NAMS website and also on the YouTube channel. So like all can visit and then they can watch it again.
Yes, we have NAMS YouTube channel right now. Even after this session, you can just go to the YouTube, just type NAMS and you can download the session. Thank you so much. Over to you, Dr. Jaswant.
Thank you, sir. So with your permission, I think we can we can mark the closure of this session. Thank you, sir.